Welcome to our live stream. I'm Dr. Deuk, CEO and founder at the Deuk Spine Institute. It is October 12th, 2023. Our patient has two herniated discs that are causing symptoms such as neck pain and arm symptoms, as well as facet joints that are causing pain. We just treated the facet joints. Now we're going to do her discs. 2, 3, 4, 5, 6. She has a very long neck. Our first step is to place this needle into the discs that we're going to be treating. We're going to start with the bottom one shot, AP. The AP shot is a fluoro shot with an X-ray that shows us where the spine and needle are. Okay. You can see that the trachea and esophageal temperature probe have been displaced to the side. Shot. 2, 3, 4, 5, 6. Shot. Shot. AP. Quick AP. Looks perfect. Lateral. The surgery you're watching is the most advanced spine surgery in the world for a herniated disc. It's called the Deuk laser disc repair. It uses a combination of minimally invasive surgery of the spine with endoscopic and laser to repair herniated discs without fusion, without metal. It's all natural procedure. There's nothing unnatural in put into the patient. All right, perfect. That's a great picture of the tear. Sanjay, keep that for the website. You
Yes.
see the tear there?
Yes, doctor.
Can you do a screenshot?
Yes, I'll do that.
All right, put the arrow there. It's perfect. Keep the arrow there. You can see the tear. The black line is where the tear is in the back of her disc. The dye is leaking out from the middle, going out the tear, showing us the tear, showing us where the herniation is. Great job. All right. That's a good one for the website, Sanjay.
Yes, Dr. Deuk, we
So
have
we
taken a
could capture
screenshot.
that and put it on the website, the new website, showing the annular tear in the cervical spine. Annular tear, cervical spine.
Copy that.
That's where all the pain comes from when it's coming from a herniated disc. All herniated discs have an annular tear. Can't have a herniation without an annular tear. The first step of all herniations is the annular tear. We're making our incision. It's 4 millimeters. The entire surgery will be done through a 4 millimeter incision. Looking good. One more lateral. All right, can we move that clip off her ear or wherever that is? You see it? Jordan, when you're taking the fluoral pictures before I get here, make sure there's nothing that obstructs the view. Okay? Because otherwise, we can't have reliable information about what level we're at. So that's 2, 3, 4, 5, 6. We are at 5, 6. You guys agree? The neck is supple. We've lost 1 drop of blood. All right, at this point, we've made our incision. The guide wire is in place. I'm going to remove the spinal needle. Shot. Okay. Spinal needle comes out. Take. Yep. Perfect. Shot. All right. You may notice that I have an interesting glove on. It appears to have a different look in the X-ray as normal glove. These are called radiation gloves, and they're basically designed to protect the surgeon from too much radiation exposure because our hand is right in the line of fire. We're still getting radiated, which is not good, but radiation is part of our job. We get radiated. It's like working in a nuclear power plant. You're going to have radiation exposure. It's part of the job. You want to monitor it. You want to make sure you don't have too much radiation. The thing about radiation is that it's cumulative. It adds up over time. It never goes away. So the effect of radiation is cumulative, and it mutates DNA and causes cancer and other problems. So you want to minimize the amount of radiation you get. In spine surgery, we get a lot of radiation because we're working with X-rays in all of our surgeries. So the more you can reduce the amount of radiation you're using during surgery, the better for everybody: staff, surgeon, patient, anesthesiologist. All right, good. You can see the tip of my dilator is literally in the center of the spine at the front of the disc. The next step is going to be to advance this dilator down. And you're pulsing, correct?
Yes, sir.
Yeah. And I would just say that with regards to the radiation, the best you can do is to use it as little as possible, but don't skimp on it, meaning, you know, don't not get pictures, get the pictures you need. Shot? But you can buy the best radiation equipment, right? Like this machine we have now is literally the best in the world. We spent a lot of money for it. Any twitches? Burn this. Right. She just seems quite tight. All right, so
0 twitches.
wonderful. Thank you. Now this disc space is more collapsed than the one above. 2, 3, 4, 5, 6. Any questions from the audience?
No questions.
Shot? We're right on top of the spine. Show us the tip of the tube. There you go. Now I've got to advance that tube down. Let's have some inline traction. Shot? Shot? Huh? Just whatever's safe. Don't do any more, Luis, he's saying. I think he's saying. Just grab her by her ears, her occipital region, and just pull her towards you.
Maybe the extension makes her feel a little tighter too.
Could be, yeah, you're right. It could collapse the back of the disc. You're right. That's absolutely true. All right, so Sanjay, why don't you show our audience how this herniated disc can cause so much pain? What's the way it does that? Just a little bit more, and we're almost. All right, welcome back. Let me show you where we are with the surgery. Can you see this here? Sanjay, I need you to answer. Can you
Yes.
see this here?
Yes, doctor.
Just answer.
Yes.
Okay? It's a communication, a dialogue between you and I.
Yes,
It's
doctor.
like when you talk to a computer with a program. You want to give an input, get a response. Okay, I need a response from you, so
Yes.
I know where you are.
Yes, doctor.
You can see our patient is here, intubated, asleep, covered. This is the right side of her neck. The middle of her neck is here. She's looking up at you, and her two herniated discs are worse on the left side, causing left arm symptoms. We always start on the opposite side of the arm and go and fix the disc that way. We have a tube. It's 4 millimeters wide. You can see it right there. You see the tube? The entire surgery will be done through this tube.
Yes.
This is a fluid adapter. And these are grabbers, pituitary rongeur. They're designed specifically for endoscope. Can you not make noise while I'm talking?
That was me. That was me.
You can see they're designed for endoscopic surgery. And when you reach in there and try to grab, nothing comes out. That's where the laser comes in. You cannot just grab out herniations when the disc is severely degenerated. The herniations are scarred against the annulus. So you got to use a laser to release the scar tissue. Now watch how easy the laser is able to remove these herniations. It's a combination of two things. One is the laser energy, which causes a breakup of the protein bonds. The other thing the laser does, which is very important, is it causes a cavitation wave, like a shock wave, every time it pulses. What's our hertz right now? What are we at, 15 hertz?
No, it should be 10.
10 hertz?
Yeah.
All right, so we're at 10 hertz. That's 10,
The only thing that you have to do here is helping.
10 cycles
It's going to twist, so you grab.
per second.
Okay? I'm helping. All right?
And every time it cycles, it releases a burst of energy.
No, I'm going to be here.
Don't be afraid.
So you're going to see.
Just do a good job.
So you're going
It's
to
easy.
you're going to see when he starts twisting.
I'm not asking you to conjure up spirits, make me a martini. I'm just asking
Probably
you
make a good martini.
to handle the laser fiber, hand the proper equipment. Okay, any questions?
Yes, we have a question from WDWL-TV
All
on
right,
YouTube.
we'll take it in a minute. I'm not ready for the question yet. I just want to make sure we have questions. So you saw the video. You see how a herniated disc occurs and how it causes pain. It's actually not the herniation that causes pain. It's the inflammation that happens after the herniation. Not everybody gets inflammation. Not everybody has inflammation that causes pain. Only certain patients have inflammation that cause pain. Okay? There's a piece of herniation right there.
Okay, you want
That's very scarred up. You see how scarred it is? It's
Yes.
scarred because it's been there a long time and it's created a lot of inflammation over the years. That piece that we just cut in half, that piece has been there for years. Many years. Okay?
Is that called calcification?
That's not calcified, no. It's starting to get some calcium deposits, but we wouldn't call it a calcified herniation. The calcium is the gold color you're seeing, the yellow color.
Okay, so it's in there.
That's calcium.
Okay.
The laser interacts with calcium. Oh, look at that herniation there. So I have to cut this thing in half to get it to come out. Now watch, it's going to float up. Okay? If I can make it light enough, it'll float up. So I have to cut these herniations in pieces so they float up. Otherwise, I have to reach down and try to grab it out. But the floating is always better. So I just sit here and I'll cut these herniations into pieces and remove them. It's the best way to do it. And just to give you an idea of the scale, oh, look at that piece of herniation that just came out. That was pushing on the nerve. Really nice. Really nice. Sanjay, this is a good one to use for the website if we want to show some footage.
Okay.
All right, because it's very clear. I have other ones too we can go through, but you know, some of these pictures are nice. Look at that piece. There's another piece of herniation.
Yes.
That was like a threesome right there. Three's Company. So that came out from that gap right there. That is where the nerve is. And that's at the back of the disc. So we just removed the herniation from the neural foramen. Where there's another one. So we've already removed about 6 or 7 pieces, right? All of this is being done with a 4 millimeter incision in the skin, and we're leaving the patient's natural disc. We're not taking her disc out. Every other spine surgeon in the world takes the disc out. And when they do that, to get to the pieces in the back, when they do that, they have to fuse the disc, or they have to put an artificial disc. We're not doing any of that. It's all old technology. We're doing a more advanced procedure, a newer procedure that other surgeons don't know how to do and are not capable of doing. This was developed here at Deuk Spine. It was developed from a combination of anterior cervical surgery on the disc with endoscopic surgery with laser spine surgery. So we combine multiple techniques here at Deuk Spine to do what's called the Deuk laser disc repair, where we're using this laser here to repair the disc. Now the patient's going to have to help me because she's going to have to do some of the repairing herself. Okay, surgeons, we actually don't do everything we say we're doing. When we say we're doing a fusion, we're not actually fusing. We are putting bone graft and a cage and a plate, but the patient has to do the fusion themselves. It takes 6 months for the patient's spine to fuse after the surgery. We call the surgery a fusion even though it's not really a fusion. The patient is the one who does the fusing. So in surgery, we often call our procedures names that really reflect the ultimate goal of the procedure, though that's not necessarily what we did during the procedure, if that makes sense. All right. Now this lady is a composer. She's a musician, a professional composer. And I've already talked to her because my son and my wife and my daughter are musicians. I'm not. I told her the only thing I did musically in my life, I was a DJ. There's another herniation. And I wasn't a DJ like the ones you guys see on TV today. Those guys and gals are famous and they make a lot of money. I actually volunteered at the UC San Diego radio station when I was an undergraduate student at UC San Diego, and I didn't get paid anything, which is fine. I wasn't looking for money. I just wanted to be a DJ and spin records. And that's what I did for a couple of years. I still have my FAA license for broadcasting. All right, I'll take the first question from our audience.
Yes, so the first question comes from WDWL TV on YouTube.
Thank you for asking.
I had a fusion, C5-C6 fusion 10 years ago. The pain never went away. I'm now on 3600 mg Neurontin and 100 mcg H fentanyl. Should I request a MRI and send it?
Absolutely. Your pain can be eliminated 100% without taking, you don't have to take any more drugs when we're done. Your pain is probably coming from what we call adjacent segment disease, which is the discs or facets above or below your fusion. And I'm very sorry this has happened to you, but we see this all the time in patients. And the reason you're having your pain, because you said it never went away with the surgery, that means the surgeon did not do the right surgery. Okay, it's that simple. And we see that all the time. The surgeons, unfortunately, they want to fix one disc at a time. So if you have 2 or 3 bad discs, like this patient, they will only fix one disc and then you'll have to come back and get another surgery done. Well, we don't do that to our patients. We fix all the pain sources that we can find with one surgery. So when we fix you, properly. So I would expect you to be out of pain completely and to be able to get off those drugs. Completely. That's what I would expect for you. I just need to see your MRI, a newer one, and I need to do a telemedicine exam. We do that for free, no charge. And then I can tell you why you have pain and exactly what you have to do to fix it. I need 1 more minute here on this disc. You got to keep all this from my hand has to come here, so you got to keep all that away from my hand.
Okay.
Okay. Just practice, you'll get it. Here's another piece of herniation that's very scarred. See all the white stuff? See the calcium, the gold stuff?
Yes, we do.
That's an old herniation, like probably 10 years, maybe 15 years old. Here it comes. Okay? Now, some people say to me, Dr. Deuk, can you get all the herniation? No. We can never get all of the herniation. No surgeon in the world can get all of the herniation. Impossible. Okay? Doesn't matter who does your surgery, how they do it. At the end, if you get MRI, you're going to still see some herniation. There's another herniation. You're going to always see some herniation there. Okay? You're going to see bone spurs there. We don't do surgery to make your spine look good. We do surgery to make your spine feel good. Okay? And there's a difference. You'll never have a normal looking spine once you've injured it. It's impossible to make it look normal. So don't expect the MRI to look normal. Okay? I want you to feel normal at the end of the surgery. No pain. All right, next question.
The next comment is from Pompino Mike on YouTube. So I'm going to summarize what this patient wants. So he has a right foraminal disc protrusion and it's severe right foraminal stenosis. His pain ranges from 4 out of 10 and some days 8 out of 10. He wants to know the next step.
The next step would be to send your MRI to Deuk Spine through our free MRI review and have me look at it and determine what needs to be done. I can't do that based on your description or your report. I have to see it myself. So that's why we do the MRI review for free, so people can get answers. But we can tell you exactly what to do to get out of pain completely if we can do the MRI review with you. All right, we're done. There may be one more piece there. Let me just take a look. Yeah. By the way, for reference, for those of you interested, the laser fiber, the glass part, not the blue part, but the glass part, is 1/2 millimeter. Okay? 1/2 millimeter. 0.5 millimeter. So you can see from that the crack at the back of the disc is about 1/2 millimeter crack. Okay, because the glass fiber barely fits in the crack, right? So when I'm done with this surgery, the annular tear has been debrided and the crack is 1/2 millimeter wide. We have a little bit more. How's my irrigation, guys? Okay, good. So what's going to happen after I do this debridement, her body will then seal that crack itself. And it'll take her 9 months to 1 year to do that. But that's natural healing. Almost done. These aren't really herniated. This is actually part of the annular tear that I'm debriding with a laser. Oh yeah, look at that. All right, I think that's it. Let's see if I can get this to float out. I'm gonna have to grab it out.
Same thing like that. Watch this tip.
Yeah.
If you hit it, it's gonna.
Is that me?
break it. Yeah. Same thing,
No,
but more gentle. It's
Okay.
very delicate.
no. It's not coming out. The problem with the grabber is you can't really use it to find the herniation. There it is. There it is. I'm going to have to cut it in half because it's too heavy to float out. So I'm going to take some pieces off and lighten it up. And hopefully then it will float out. I may be able to grab it now. But that's what this surgery is. It's basically just going back and forth between the laser, doing a debridement, and the grabber removing pieces. No. Thought we had it. This guy is just hiding. Every time I go back in, he's hiding in the crack. Yep. All right, looking good. Let me just flip one more time. This is very calcified here. You see the gold? It's not white, it's actually gold. And when I say calcified, it doesn't mean it's a calcified herniation like most doctors talk about. Calcified herniations are all calcium. That's reserved for that type of a herniation. But you could see the microscopic calcification that's already happening for that herniation. Maybe another 30 years it would all be calcified. All right. Any more questions?
No questions.
Done. So we're done with the 5-6 disc. Now we're going to go to the number 4-5. I use a little betadine to irrigate. Good job. Yeah. Any questions?
No questions.
Let's show the audience our video explaining how the Deuk laser disc repair works. Come back. We're done with the 5-6 disc repair. We're going to move up to the next one. 2, 3, 4, 5. I'm going to come out of the disc. Shot. Nobody move. I need to get out safely. And this is, you got to really feel as the surgeon with your fingers. I'm right on the edge. I can feel a bone spur there, yeah. So I got to slip above. There we go. Shot. So I'm still on the bone. And I got to check my AP, my front back view, to make sure I'm in the middle. Because when you come out of the disc, you can slide left or right. You don't want to go left or right. You want to stay dead center. All right, I am still in the middle. That's great. So I'm going to go back to my lateral view and move myself up to the next disc. I want to hover right over the opening or entrance of the disc. I'm halfway there. I feel the ALL I just did. All right, so we're there. Now I've got to check my left-right again through an AP view. If you do not check your AP view, you could end up going off on the side of the spine. That's not the disc. You want to be in the disc, not in the soft tissues of the neck. Right, Dr. Berndes? All right, so we are now entering that disc. Shot? I'm going to start by doing a discogram so we could see the tear once again. Are we back?
Yes, we are.
Thank you. All right, here we go. Discogram shot. There's the tear. You guys see the tear in the back? Shot? Shot? Yeah?
Yes, we do.
All right. All right, very good. So I'm going to now just advance this dilator a little more. I'm going to tell you right now, this herniation is a newer herniation. 2, 3, 4, 5. Because the last one was more degenerated, this one is softer. I'm actually able to twist and deliver the tip to the back of the disc where the tear is. Okay? I may go a little bit more. Shot? Yeah, but we're there. So now I'm going to bring this tube, this 4 millimeter diameter tube, down over the dilator, slide it down. Shot? I want to keep checking my dilator to make sure it doesn't move. I've seen the dilators get pushed backwards from the disc due to pressure from inflammation, severe inflammation, especially when you have an acute herniation or a subacute herniation, something that's relatively new. Shot. So you want to always check with your x-ray. Check your position. Okay, you're operating on the spinal cord here, right on top of it. So you want to make sure that you know where your metal instruments are all the time. Shot? You can't like lose track. And the way you know, see that? The dilator slid back about 3 millimeters. Shot? It slid back again. I'm okay with that for now because I haven't gotten my tube up there. Shot? But once I get closer to the end of that dilator, I'm going to need it to be in position. So I'll stop and reposition it. The problem is if you do not use the dilator, you will biopsy the disc. And we don't want a biopsy of the disc. Biopsy is a different procedure. It's where you take part of the disc out. We're not doing a discectomy. We're doing an annular debridement. We're removing the hernia. Shot? All right, almost there. Just another 2 millimeters and I'll be very happy. 1 more millimeter. I feel like I'm rubbing against the top. Shot? I think we're just there. So that's as good as I can get it safely. All right, shot? Okay, good. Show us the tip of that tube, Jordan. You guys see the tip of the tube? It's at the back of the disc. Show us the front of the disc.
Yes, we do.
Front of the disc is there, back of the disc is there. Show us the endotracheal tube and the esophageal temperature probe. Good? Good. So we always know where the trachea is and the esophagus is. It's all right. Our next surgery is lumbar. Deuk laser disc repair, 3 levels. Patient with herniated discs in his lower back and back pain. Look at those pieces of herniation. I'm going to go grab them out. How's irrigation? Thanks. Any questions from our audience?
Yes, we have a question from Earthbody Official. If my MRI says osteophyte complex or bulge, but it's difficult to see the extent of osteophyte, do you suggest a CT scan to confirm how much bone spurring is happening on the vertebral posterior side?
Yeah, great question. So the question is, Dr. Deuk, MRIs are really good at looking at disc herniations, but they're not so good at looking at osteophytes. Do you want me to get a CAT scan so you can have a better idea of how much osteophyte there is? If I want to know how much osteophyte there is, I would get a CAT scan. If I'm not as interested in that, then I won't get a CAT scan. With your case, I have no idea. I haven't seen your MRI, I don't think. Or maybe I have. But I would never want you to get a CAT scan without first seeing me and doing a telemedicine consult. Or I look at your MRI and decide if I want a CAT scan. I hope that makes sense. In other words, I don't order CAT scans on every patient with bone spurs. Okay, there's no need to do that. It's excessive and unnecessary. And don't forget that CAT scans are radiation, the bad radiation, X-ray radiation. Okay? So I don't want to order a test that's unnecessary and exposes the patient to unnecessary risk, especially from radiation. So I would say do your MRI review first, and I'll tell you if you need a CAT scan. Don't try to second guess me. I have a lot of patients who think they know more than I do, or they try to second guess me, and they're dead wrong. Okay, you may be smart, but you're not going to know as much as I do. I've been doing this 26 years as a neurosurgeon. It's always best if we work together to solve patients' problems.
The next question comes from Tiras Estella on YouTube.
Nice to meet you. Thanks for joining our live stream.
To reach out to the disc herniation, dilator is inserted from one end.
Sanjay, it's really hard to understand you. You're not enunciating.
To reach out to the disc herniation,
To reach out to the disc herniation?
yes,
Okay.
dilator is inserted from one end.
Is inserted from what?
One end.
Yes, the front of the disc in the cervical.
And after removing the dilator, is there any chances that nucleus pulposus comes out from the source end?
No, there's no chance. Because the fibers in the front of the disc close after you take the dilator and tube out. They close. Think of the dilator as being a pointy thing like a pin going through your shirt. If you want to pin something to your shirt, does the shirt have a hole after you take the pin out? No, it doesn't. The pin just separates the fibers. Okay? The pin does not make a hole. If you put something too big, you can make a hole. You'll tear the fabric. But the front of your disc has a fabric. Okay? It's a fabric. It's called fibers for a reason. Annular fibers. If you look it up on the internet, you'll see it says annular fibers. It's not called fiber for a reason. No reason. It's called fiber because there are fibers. And just like fibers of cotton on your shirt, you can put a pin through it, spread the fibers with the tip of the pin, and when you take the pin out, the fibers are still there. Scope on. Okay? I think we answered that question about once a surgery, right?
Yes.
Sanjay?
Yes, Dr. Deuk.
Common question.
Yes,
Good for our chat bot.
copy that. The next question comes from Pompano Mike.
Who?
Pompano Mike.
Just enunciate each word, each syllable. How do you spell it?
Pompano.
Spell.
Pompano.
Pompano. Pompano.
I just said that. Pompano Mike on
Get
YouTube.
defensive. Just fix the enunciation and we'll be good. All right, Pompano Mike on YouTube.
He says, if a patient has severe central stenosis,
Severe central stenosis.
what minimally invasive procedure can you do There is one doctor in Fort Lauderdale that uses ultrasonic technology to remove stenosis, similar to your laser.
No, he's not similar to my laser. The guy who does that is removing the normal bone out of the back of your spine. You don't want that done. You want the actual source of the herniation or source of stenosis to be removed, which is your disc herniation, not your lamina. The ultrasonic machine only removes bones. And the only bones involved in stenosis, there are no bones that cause stenosis. What causes stenosis is disc herniations. Disc herniations are in the front of your spine. The ultrasonic machine only works on the back of the spine. And he's going to be removing your normal bones in the back of your spine. Bones that should not be removed. It's a procedure called a laminectomy. Okay, laminectomy. So he's using the ultrasonic apparatus to perform a laminectomy on you. You don't want a laminectomy. Laminectomy is removal of normal bone out of your back. That's the bone that's going to stabilize your back and keep you from having instability, your spine falling apart. So don't let anyone take bone out of your spine. These procedures that we do treat stenosis, but they do it by attacking the source of the stenosis, which is the herniated disc, like this right here that we're seeing. And we don't damage any of the normal parts of the spine. The ultrasonic treatment removes normal parts of your spine, okay? Don't ever compare my treatment with his. You can ask about the differences, but we're actually treating the source of pain and the source of stenosis. There's another herniation. See that? All we're doing is removing herniation. We're not taking bone out.
Yes, we do.
Next. About 4 minutes left, 5 minutes max. Grab her. See how small it is?
Yeah.
It looks big because the endoscope makes it look big. Scope on. But it's actually, they're all a bunch of tiny little pieces.
Do you feel like the newer herniations or the older herniations are harder to get out?
Oh, the older herniations are harder to get out. The more degenerated the disc is, the harder it is for me to fix it. Her discs are quite degenerated, but there are pieces of new herniation I'm seeing, and we've been taking them out. Like that one I just got out.
Yeah.
That was actually on her right foramen. So she's going to end up having right arm symptoms at some point soon if we didn't do this. So I'm able to fix both sides through one incision in the middle. Look at that herniation. Here it comes. You guys see it?
Yes, we do.
It looks like a baby coming out. Look how the edges of the herniation are all like little finger projections. That's because it's a newer herniation. That is literally in her right neuroforamen, on her right arm. So, oh yeah. Look at it. Oh, it's beautiful. Absolutely beautiful. This is the most, oh, there it is. It just came out. Okay? And it would not have come out if I didn't use the laser. It's impossible. That's why the laser is so important in fixing people's herniated discs. It's not possible to do it without. Let's show the size. Remember how big it looked on the endoscope? Here you go. Look how small it really is. Can you see this?
Yes, we do.
It's literally 0.5 millimeter. Sorry, it's literally 5 millimeters, not half
I
a
don't
millimeter.
know. It's
Huh? Can you see it?
yes, we do.
It's half a centimeter, so 5 millimeters, okay? Here you go. We should be done in just a few minutes here. Let me just take another peek. Come on. I'm really happy with the way things are going. Hey, yeah, don't put the weight. She's doing great. That foramen is now nice and clean. These are a few more little pieces of herniation that were out that foramen, but you can see her chief complaint was neck and left arm symptoms. This is in the right side. So it was just a matter of time before the right side was going to start bothering her. Oh, another herniation. Look at that. I mean, I don't remember seeing all this on the MRI. So what I'm getting at is this has all happened since her MRI, okay? So remember, the MRI is a snapshot of what's going on at a certain point of time. But people get worse. There's another piece. It's about 4 millimeters. And so if the MRI was done 3 months ago, the patient may have herniated more since then. And that's why this surgery is more sensitive, because I'm actually in here seeing the herniations. And that's the foramen right there, the neuroforamen. I think she must have herniated this recently, because I didn't see so much herniation on the MRI. On the right side. Her left side was worse, symptomatically. Yeah, I didn't expect to encounter this, so about 2 minutes, yeah. Yep. Just this, I mean, I can't imagine this foramen has that much more herniation in it. All right, questions from our audience.
We have a question from Pompano Mike on YouTube. I noticed on your website you offer PRP injections.
Yeah.
What has been the success in PRP reducing pain compared to TFESI?
All right, I heard what has been the success of PRP reducing pain from what?
PRP reducing pain compared to TFESI.
Compared to an epidural. Oh, epidural is better, but I don't even recommend epidurals.
You said TESI.
Yeah, transforaminal epidural steroid injection. Okay. The foraminal, the steroid injection is better than PRP for spine disc issues. I would not do PRP. PRP is a waste of money, and it could be dangerous for you. PRP is good for other types of joints, like hips, knees, not good for discs. Save your money. Stop wasting money on procedures that don't work. Move your hand, please. Come to Deuk Spine and get a procedure that actually works. Yeah, I mean, it's, for some reason, it's like the gift that keeps giving here. No, don't push. No, when you touch this, look what it does to the tip.
Yeah,
It moves the tip around, okay? You got to let me put it in, then you can pick it up and support it. Shot? Or scope on? All right. All right, I don't really see that much more. I'm just cleaning up what's left here. Flip it. I don't know why we have cables everywhere. Just about done, guys and gals. That is a bone spur right there, but I don't see anything more. Yeah. People ask about bone spurs. We don't take all the bone spurs out. There's no reason to. You're not going to get them all. There's another piece of herniation right there. Ah, it's too heavy to come out. How's my irrigation, guys? looks good to me.
Okay.
All right. We're done.
Sitting on, please sitting. Yeah, thank you.
If you have questions, type them up. I'll come answer them for you face to face. But we are essentially done. I want to show you the incision. The patient has been asleep for the whole surgery under general endotracheal anesthesia. We're supporting her airway, supporting her ventilation. Now, that said, she's going to go home this afternoon. I mean, not this afternoon. Let's see, it's 11:40, so yeah, this afternoon. She's going to go home in about an hour, hour and a half. All right, Sanjay, I'm going to show you the incision, and then you can go to one of our patients who had the procedure and show the audience.
Copy that.
So I'm going to hold pressure for just a second, okay, in case we have any vein bleeding. And you guys see the metric? Can you see that?
Yes, I do.
There's the incision. Can you see it?
Yes, I do.
It's just like a little pinhole. All right, hold pressure here. And let's put some steri strips. Let's go ahead and go to our testimonial, and I'll be there in a few minutes. Type up your questions for me. But we've just completed a 2-level Deuk laser disc repair, cervical, C4-5, C5-6. We found a lot more herniation than I expected at C4-5, especially on the patient's right side. That was a bit unexpected, but that's why at the time of surgery, being able to see back there with the endoscope makes it important, because you can see if there's any new herniations. All right, go ahead, Sanjay. I'm Dr. R. Deuk. I'm here with one of my patients on February 1st, 2023. And you just had surgery on your neck, the Deuk laser disc repair done with a 4mm incision to fix 2 herniated discs, her C6-7 and her C7-T1. And you had a long neck. We were able to get down to the C7-T1, and she had a very large herniation there. So your surgery was about 24 hours ago. How do you feel today?
I feel like a different person. I feel I was able to do many things this morning that I haven't been able to do for 4 months, and that is just get out of bed and just take my first steps and have 0 pain. And I haven't had that in 4 months. First step out of my bed was always the beginning of my day, and it was awful. And today I took my first step out of the bed and it was glorious. Good for you. And before surgery yesterday, you had been suffering for about 6 months with neck pain going into your right arm, correct? About 4 or 5 months. How did that affect your quality of life? Every day is difficult. I mean, I have a 10-year-old and a 5-year-old boy, and just the basic duties of a mother every single day was just unbearable and difficult. So quality of life was not very good. And so it is now. And so the pain, obviously, because of the pain, activities would set it off, so you were limiting what you were doing. You were limiting what you were able to do as a mother. Yes, there was things I were not able to do, and be the best mum that I can be was not one of them. Well, you look very happy right now. I am. Why are you so happy? Because I'm pain-free. Yeah, and you didn't have to have a fusion or an artificial disc put in your neck, did you? I did not. Did anyone offer those surgeries to you? I did. I was offered those surgeries. I was told that I needed a fusion, the possibility of disc replacement in 1 or 2 years down the road, but it was my decision to go in and have those taken care of if I wanted to. But there was also a possibility that once the doctor got in, that he could not replace those 2 discs, so he'd have to fuse those 2. So that to me was a possible 3 discs being fused. Mm-hmm. And I know the consequences of that, so that's why I came for your opinion, in your professional opinion, what can be done in a less evasive way. Or that was an option for me, and here I am. And I'm really happy it worked out for you. You can see in the video, we were able to get down to C7-T1, which is really a first endoscopically. And, because you had that nice long neck, we were able to do it. And there was huge pieces of herniation down there.
Your other disc was more degenerated, and we were still able to get that fixed as well. So I'm very happy you're doing well. What's life going to be like now that your neck is fixed?
My quality of life is just going to be a lot better than what it was. Just, I'm going to take it easy, and I know that I need to take it easy, and I'm going to be careful, but I'm going to wake up with a smile on my face now instead of tears.
Well, congratulations.
Thank you so much.
Is there anything else you want to tell your fans out there?
Come see Dr. Deuk. He'll fix your pain and make you walk out with a smile on your face.
Excellent. All right. Good to see you. Good
Thank
to see
you. Thank you so
You're
much.
welcome. Good morning, I'm Dr. Deuk. It's December 9th, 2022, and I have with me one of my patients who traveled from out of state, Texas to be exact.
Yes, sir.
And he is suffering with neck pain, and I'll let him tell you a little bit more about his symptoms, but he had herniated discs in his neck along with degenerated disc. We just repaired those yesterday, less than about 12 hours ago.
Yes,
as a matter
sir.
of fact.
Yes, Doc. Yeah.
You're here now on post-op day 1. It was outpatient, no hospitalization. You stayed at the hotel. You're back this morning, and how do you feel?
I feel great, Doc. You know, I just want to thank you right off the bat for you and your team for basically giving me another lease on life. I mean, the back of my neck, the tops of my shoulders. I had pain all the way down the back of my arm, and my elbow, and then also I had no grip. And today, it's all back. I just, you know, it's just a game changer. His procedures, because I've had fusions in the past, like 15 years ago, and those fusions, you don't want to do those because they just give you adjacent disc disease, and I have that problem right now on my back, and Dr. Deuk is going to fix it next week. So I'm very looking forward to doing that.
We'll be seeing him again next week after his back is fixed. But you broke it up into 2 procedures, and we get people all the time asking us, oh, can I come there and get my neck and my back fixed? Yes, you can. We'll probably do it on separate days. So you got 3 discs repaired yesterday. You can
Yes, sir.
actually see right here in this video footage how small the incision is, tiny. And I was in there endoscopically using a laser to clean out the tear and remove the small herniations. And now here we sent you home an hour after your surgery, and here you are back today. And how much of that pain did we get rid of?
All of it, Doc.
100%.
I mean, 100%. And I mean, the doctor did. They did surgery on 3 different levels, and through a really small hole.
4 millimeters.
Yes,
4
Doc.
millimeters. Incredible.
There's no stitches. It's just a Band-Aid.
Yeah.
You know, that's crazy. You know, if you have a fusion for 3 level fusion, I don't know how long that would be, but it's
it's
terrible.
about that long for a 3-level fusion. And then of course you'll have swallowing trouble for months, and then you'll have pain, and you'll be on narcotics. Are you on any opioids or narcotics?
No, Doc. Last night I went home and to the hotel, and I just took a Tylenol PM, and that's all the medication I've taken since the surgery.
Yeah. So with the Deuk laser disc repair, you don't have to worry about getting addicted to painkillers because there are no painkillers. Literally a Tylenol, and that's it, because it's so minimally invasive. Far better than ACDF, far better than any other cervical type of surgery. Well, is there anything else you want to tell your fans out there before we wrap this up?
Yeah, I just want to let my parents know, and my 10 younger brothers and sisters, if they're watching this, if you have back issues, you need to come see Dr. Deuk, because he is one of the only people in the world that can do this procedure, and it is a game changer, and it's well worth it. At least give him a review. He'll do a free MRI review for you. It's just do your research. Go to his deukspine.com, look at his website, and just do your research and give yourself a chance to do the right thing.
Well, thank you. And yes, now I'm the only one, but someday there will be another one who will be doing these surgeries, and probably better than me.
Okay, thanks, Doc. Appreciate
Thank you,
your help.
sir.
Yeah.
We'll see you soon.
Yeah.
Should be. Okay, hi. I'm Dr. Deuk, and we've just completed a surgery on a lady who's traveled here from far away. She and I had a great conversation in clinic, She's actually a musician. She's a composer. She's been having a real hard time doing her compositions because she's in so much pain, and the pain is in the neck. It hurts her to move her neck. It hurts, goes down her arm. It was her left arm. But when we were just in there at the 4-5 disc, we found lots of herniations on the right side up against the nerve. It was just a matter of time. She would have been having right arm symptoms as well. But I got all the herniations out of the foramen, and we cleaned up the disc as best as we could. And understand, at the end of any surgery, the disc will never look normal, okay? So people have to understand, we're not trying to make your disc look normal. Normal looking doesn't equal no symptoms. Normal looking doesn't equal no symptoms. So the goal of surgery is to eliminate what are called signs and symptoms. Signs are physical exam findings such as weakness, numbness, reflex changes, myelopathy, basically findings that doctors know how to look for. And symptoms are what patients complain about: neck pain, arm pain, tingling, numbness, weakness. There is some overlap, and but they're not the same. So a patient could come in, they say, I don't have any weakness in my arm. When you ask them, do you have any weakness, they say, no, I just have pain. And then you do an exam and you find out, oh yeah, you're weak in your arm. And we know how to look for that as doctors. We gauge one side versus another, but then again, we also have, 100,000 patients that I've examined their arms to see who's got normal strength. So I know what normal strength is like, and I can gauge them against my collective knowledge based on years of experience of doing the tests. And that's not something the patient's complaining about weakness in their arm, but that's something I found on exam. So we call that a exam finding, or we call it a sign, S-I-G-N. And our goal with spine surgery is to normalize the exam and normalize the symptoms, those two things. It is not to make your spine look good. So people got to understand, we're not in the business of, doing an augmentation of the spine for aesthetics. We're in the business of getting rid of pain. And I can promise you, 100% of my patients that I do surgery on, we get rid of their pain, but we also do not make their spine look normal. Their spine still shows bone spurs and bulges and annular tears, and there's still going to be stenosis in most cases, right? But it's to make it so that those findings are not symptomatic. They're not causing any problem for the patient. And that's the best we can do in medicine. All right, first question.
The first question comes from Warrit on YouTube.
All right, how do you spell it?
W-A-R-I-T.
Warrit. So W-A-R is war.
Mm-hmm.
Say it.
War.
Good. It.
Warrit.
Perfect. Warrit.
Yes.
I wore it.
Can the degenerated disc got the water back again?
Can the degenerated disc get its water back again? Never. It is not possible. People are trying to make things to make that happen. It's garbage. I wouldn't do it. I wouldn't waste my money. I wouldn't have a procedure where they're trying to put water back in your disc. You don't need the water. Okay? Totally unnecessary.
The next comment's from Earth Body Official, and he's trying to follow up on the osteophyte complex.
Sure.
You did look at my MRI, and the other surgeon asked me to do CT scan. If a CT scan shows a lot of osteophyte on the vertebral side, how much of that can you remove with the laser?
Yeah, so if there's a lot of bone spurs, it depends on where those bone spurs are located in your spine. Every spine surgeon is going to have difficulty removing bone spurs, whatever technique they use. So we don't go in there to remove bone spurs. If you want to have bone spurs removed, go somewhere else. Don't come to me. If you want to be out of pain, you want to treat your problem properly, you come to me. But if you have tremendous amount of bone spur, I'd be interested to know about that in advance. But it most likely will make no impact on my recommendation. But it's good to have. If you're going to get the CAT scan, feel free to send it to me.
We have a next comment from Earth Body Official again. If the laser can't get all of the osteophyte spurs on the vertebral side, can you use the instrument to scrape out the spurs off through the scope?
No, you can't use an instrument to scrape out the spurs through the scope. Nope, you don't need to.
The next comment's from Diro Stella. I believe patients are allowed to lift up to 20 kg post DLDR surgery in the first year. And how much will this impact on their sexual life if somebody is planning for a wedding in next 2 months of DLDR?
So the lifting restriction for this type of surgery, the Deuk laser disc repair, is 25 pounds, not kilograms, 25 pounds in the first 6 weeks, and then it goes up to 40 pounds. I wouldn't want you lifting 50 pounds for sure. How many kilograms is that? I think 20 kg would be too much. As far as sexual activity, you know, you can have the surgery done and you can get sexually active 2 weeks after the surgery, but you know, when I say that, there are people who have an idea of what sex is. It's very different than other people. So I think, you know, as long as you're doing nothing too strenuous, nothing like a pretzel position, then it's okay. But you just have to understand, if you do too much, you're going to reherniate. And reherniation means more surgery. We're going to have to go back again. The reherniation rate for our surgery is 1%. 1% of our patients need to go back to surgery again because they did something they weren't supposed to do. They did too much, too soon. After 1 year, you can do whatever you want. You can go on a trapeze if you want and have sex. But, you know, the first year you have to take it easy. I think Sanjay is blushing. All right, next question.
The next question comes from Deuk on YouTube. In researching the cause of disc annular tears, have you ever heard of possible mycoplasma infection being the root cause?
Dave Cook, mycoplasma infection is the root cause for annular tears. Never heard of it. Never thought about it. I mean, I assume anything's possible, but I got to be honest with you. If I had to give it a probability that it's mycoplasma infection, I would say it's 1 in a million chance. The reason for that is unless mycoplasma has a predilection to the annulus in terms of infecting it more than any other part of your body, it would be unrealistic. Second of all, mycoplasma is an obligate intracellular bacteria, and it lives inside the cell, and there's no cells in the annulus. It's all collagen and elastin. It's fibers. So I really don't think an infection of the annulus is likely, mostly because, number one, mycoplasma has to live inside of a cell to infect, and there are no cells in the annulus. There's just fibroblasts, but there are very few of them. Second of all, how does it get there? Like, it'd have to be through the bloodstream, and then why would it? The disc doesn't have much blood supply, so it would be very unusual. I would say that the chance is probably 1 in a million that it's a factor. But thank you for thinking about it.
The next question's from Pompano Mike on YouTube. He has a set of 3 questions. After the MRI review and the patient decides to do DLDR, what happens next? Does the patient come in day before or same day as surgery? Do you take standing x-rays, MRI, need cardio clearance?
Great questions, Pompano Mike. So the way it works is we like to get everyone to the MRI review because, to be honest with you, a lot of patients, and I don't blame them for this, is they have been living in pain for years. Their doctors have failed them. They haven't given them the right diagnosis or the right treatment, so they continue to suffer. They're spending money, time, doing treatments that don't work. So patients have lost faith in the medical system. And what I find is that a lot of people are trying to kind of solve their own problem, right? Even I had to do that, honestly. For my sinus, I had to go back to my ENT. I've had 4 surgeries. And, you know, I had to go back to the ENT and tell him what was wrong. He's a friend of mine, and he did a good job with the surgery, but I had to tell him what I needed done. And I'm a neurosurgeon. I'm not an ENT doctor. I don't know much about sinuses. So yeah, I know what it's like to have to figure out your own problem. And I know that all you guys are doing research out there. But I could tell you, no amount of research you do will ever come close to understanding what I do. So when I tell you something is not an issue, it probably isn't an issue, okay? Just because I've been doing this successfully in at this point over 100,000 patients, successfully treating their back and neck pain. And what I'm saying to you is you guys have knowledge, more knowledge than most doctors. I give you that. You're right. But it becomes a problem for me when I have to constantly try to explain the same thing over and over again to somebody. So I don't have a problem with learning, it's good. I don't have a problem with teaching, it's good. But there are certain types of people that want to keep challenging me on my decision. And the truth is I'm too busy to sit there and have to rehash things over and over again with the same person. And I think most people are that way. They don't want to be bothered by it. At some point you're going to have to trust. We put, hundreds and hundreds of testimonials, people that we fixed. That's not even all the people we fixed. We cannot do all the testimonials because there's too many of them. And those testimonials take time to shoot and to edit and, to put on there. And, it just takes time. And so we are unable to put all of our success stories out there. You're seeing about 1 out of 5, maybe 1 out of 10. So what I'm getting at is we have successfully cured back and neck pain in thousands upon thousands upon thousands of people. So we know exactly what needs to be fixed and how to fix it. That said, when I do an MRI review, I need to actually see the images of your MRI because I've got to look through them. And if you do an MRI review with me, you'll see that I don't just look at one picture. I scroll through. I'm looking at multiple pictures at the same time, and I'm scrolling through different sequences at the same time. So I'm looking at a sagittal T2 along with an axial T2, and what I'm looking at is I'm looking in three-dimensionally, reconstructing your spine in my head as I'm going through these images. And I'm looking at where are the nerves, where's the herniation, where's the tear. So a report by itself doesn't do it. I need to see the images, I need them in DICOM format, I need all of them. We plug those images into our system, and we have a computer system that basically a program that allows me to see all those images next to each other in a way that I need to see them. So the MRI review is the key to making the diagnosis from my standpoint. Now I don't just look at your MRI, I'm also looking at you. I'm looking where's your pain, show me. I'm asking where is your tenderness. So I'm actually processing lots of information at the same time in a very short amount of time. And to do that, I need the patient to cooperate with the physical exam. Where's your pain, where's your tender spot, but also watching the MRI at the same time. I can come up with a diagnosis within 5 minutes. A diagnosis that 99.9% of doctors can't figure out. Even if you gave them 100 years, they won't figure it out, okay? That's because I've successfully treated back pain for 26 years. And I've learned where back pain comes from, where neck pain comes from. And I know how to identify the source, okay? So that MRI review is very important to identify where each person's pain is coming from and symptoms are coming from, and then to make a recommendation. Once I made that recommendation for treatment, one of my team members will reach out to the person and they will offer them treatment, okay? And the way I like to do it is if you have 5 things that I find that are causing your pain, we're going to prioritize them to what I think is the worst, the second worst, the third, the fourth, the fifth. So when you talk to my agents and they're like, what do you want to do? You want to do all 5? You want to do the worst? You want to do the worst 2? You're going to be given a choice, and you got to decide. I don't tell people what to do. And if people decide not to treat with me, that's fine. It doesn't bother me one bit. That's their choice. My job is to figure out what's wrong, come up with a treatment plan that's the best for the patient, to present that treatment plan to you and offer it to you. And a lot of doctors don't get it. That's their job. It's not their job to force the patient to do treatment. The patient has to want to do treatment, has to decide to do treatment. So we'll present you with what my recommendation is. You're going to decide if you want to get the treatment or not. If you decide you want to do the treatment, you just carry on a dialogue with scheduler who calls you, and we will pick a date that works for you and a time. You'll need to show up here the day before your surgery. So if the surgery is on a Tuesday, you'll be here Monday. You'll spend all day here doing paperwork, meeting me, meeting Dr. Damola, meeting Sanjay and all the rest of the team. We're going to get you ready for surgery. And the next day, you're going to get your surgery done. You're going to then go back to your hotel, and you come back Wednesday morning, for example, and I'll check your back out, check your neck out, make sure everything looks good, you're healing well, you don't have any problems, go over the instructions with you, and then send you off. And that's it. So it's 3 days you need to be here. Actually, 2.5 days. And we do this for people all over the world. We have 80% of our surgeries now are people outside of Florida. Only 20% of our surgeries are people inside Florida. We're in Florida, folks. We're over in Melbourne by Space Coast, where NASA is and SpaceX. So we're used to handling out of town, out of state, out of country people and dealing with them. Do you need a cardiology clearance? You don't, unless you have a cardiology problem. So if you have a cardiologist who takes care of you because you have stents or have had a heart attack or AFib or one of those problems, then yes, you will need a cardiology clearance. If you don't have a cardiologist and don't have a heart problem, you don't need a cardiology clearance. Unless we find something on your EKG that concerns us, and then we're going to want a cardiologist to clear you. We do have a cardiologist nearby. My brother-in-law is a cardiologist, Dr. Jong. He's amazing, and he's an interventional cardiologist. So in a pinch, we can send a patient to him, have him work them up, and do whatever's needed. Okay? Great questions.
The next question is a follow-up question from Pompano Mike.
Mm-hmm.
For this patient you just finished, you just said you went into the center and you were able to remove the herniation from both right and left. Can you go through the center for L1 through L5 and get both the sides?
Yeah, it's a great question. So what we did for the cervical spine was we put our tube in the center, and now look, watch what happens. I can wag it this way and I can wag it that way. And what's moving is the tip. The tip is going left to right, but this part right here is anchored in the annulus, okay? So watch it. I'm not going to move the part where my finger is, but this is what I'm doing in the cervical spine. For the lumbar spine, we can't do that. You have to pick left or right. We're either going to go on the right side or we're going to go on the left side. There is no wagging, okay, like you can in the cervical, so it's different. But I can get to the center at L1, 2, L2, 3, L3, 4, L4, 5. I cannot get to the center at L5, S1. But at the other levels, I can start laterally enough that I can get over through the foramen to the middle. So it's not a problem.
The next question is from Becky on Facebook. If I have had a fusion at C5-C6-7 through an incision in the front of my neck, and I need a surgery on C8 to T1, is that performed in the same location?
Yeah, great question. So what Becky is asking is, hey, I had a fusion done on my neck at C5-6, C6-7, and now the surgeon wants to go down and do another disc below C7, T1. Is that done with the same incision? Typically the answer is yes, it is. That's what I would do. I would go on the same side that the other surgeon went. Because if the surgeon who did your first surgery damaged your recurrent laryngeal nerve, the nerve to the vocal cord, then you're going to want to go on the same side that they damaged that nerve, because you don't want to damage it on the other side. If you damage the recurrent laryngeal nerve on both sides, patients can't talk anymore. Like the rest of their life they can't talk. There's no way to fix it. So what I always do if I'm assessing a patient to do a fusion surgery and they've already had an incision on the right side, I'm going to go on the right side, because I don't want to go on the left side and damage the vocal cord on the other side. Then they won't be able to talk or breathe. It would be bad. They have to have a little, thing coming out here. It's called a Pessimier valve and a tracheostomy. So anyway, I don't know if that's the answer you're looking for, but I would go on the same side and I would make a different incision. I wouldn't make a transverse incision. I would make an oblique incision, because that way you can get above and below and you can find some normal tissue and develop a plane. It's safer that way for the patient.
The last question is from Vitality Approach on YouTube.
Hello, Vitality Approach. Welcome back.
if a doctor identified laxity or damage from a digital motion X-ray, would this at all be caused by herniated discs?
Yeah. So if a doctor identified laxity on a digital motion X-ray, would that be caused by herniated disc? The answer is yes, it could be caused by herniated disc. I'm laughing because the only doctors that do digital motion X-rays are chiropractors, and they always do it because if they did a regular X-ray and billed the insurance will pay them $5. But by doing a digital motion X-ray, they can charge $200 and get paid $200. It's basically just a scam, and it allows them to show you nonsense like laxity, which no other doctor looks for besides a chiropractor, so that they could show it to you and justify you paying for their chiropractic treatments out of pocket $60 a visit. These are just shenanigans that are very common in the spine treatment world, and chiropractors, I know all their tricks, and digital motion X-rays are one of their tricks.
And that's all.
All right, have a nice day. We'll be back in about 30 minutes for a 3-level lumbar Deuk laser disc repair. This patient has back pain. She's been suffering with it for years. She found us. She doesn't want a fusion. She wants me to go in and repair her disc. 3 of them, all from the same side. It's the right side. So we'll be coming in the right side, and for those of you that want to join us, we're going to be going in with that tube. We're going to start by going in at L5S1, and then we're going to go in at L45, and then I'm going to go in at L34. And I'll use the laser to repair all 3 discs. It'll take me about an hour to do the whole surgery. Hope you can join us. Thanks for being here.